With over 30 sleep coaches, MSC supports more than 60,000 CPAP patients to refresh their CPAP supplies, troubleshoot their equipment, and support their usage and compliance. Because most insurance companies allow supplies to be refreshed every 90 days, MSC has developed 2 programs to refresh supplies that patients can choose from. The first is our Courtesy Contact Program, where patients receive a call, text, or email based on their preference as they become eligible to refresh their CPAP supplies. The second option is our Auto Ship Program, where supplies are shipped to the patient based on the schedule recommended by their insurance company. MSC also assists new patients every day that receive their CPAP from another provider, but would like to receive their supplies through our Refresh program. To order supplies for any CPAP patients or to learn more about the MSC Sleep Refresh program, visit medicalserviceco.com.
I hope you are enjoying the lectures this morning. Our next lecture will be provided and presented by a true pioneer in sleep medicine. We are so pleased to welcome Dr. Meir Kryger to our educational forum, and we are truly grateful for his participation. Dr. Kryger is a professor at Yale and has been treating patients with sleep disorders for over 40 years. While many of you may have seen Dr. Kryger's name on the spine of your textbook, did you know that he is the physician credited with describing the first case of sleep apnea here in North America? Dr. Kryger is also the chief editor of the textbooks, The Principles and Practice of Sleep Medicine and the Atlas of Clinical Sleep Medicine. Dr. Kryger has published more than 200 peer-reviewed articles and several books. His book, The Mystery of Sleep, was featured in an article in The New Yorker. Sleep in Art explores how artists look at sleep. He recently published a novel, The Man Who Couldn't Stay Awake. He has been president of the Canadian Sleep Society and the American Academy of Sleep Medicine and has also served as chair of the National Sleep Foundation. Dr. Kryger has received a Lifetime Achievement Award from the Canadian Sleep Society and the National Sleep Foundation. He has been on BBC Radio many times and appeared on CNN, Good Morning America, and been interviewed by print media including the New York Times and Reader's Digest. We are grateful to Dr. Kryger for his willingness to share his knowledge and time with all of us today. So without further ado, here's Dr. Meir Kryger to present his lecture, Sleep and the Pandemic.
Hello, my name is Meir Kryger. I'm a professor of medicine at the Yale School of Medicine, and today I'm going to talk about sleep and the pandemic. Now, there are a bunch of topics related to sleep that came on during the pandemic. Insomnia, nightmares, sleep breathing disorders. Those are the issues that arose, and who was affected? The general public and patients with COVID. So as you all know, late in 2019, our planet was attacked by a never before encountered silent virus. The culprit was SARS-CoV-2, and the disease caused by this virus is called COVID-19, although there are other names for it. The commonest name is COVID-19. So my world changed on March the 10th, 2020 at exactly 7:51 p.m. with this email that came from the office of the president of the university. It started off with, "Dear members of the Yale community, I write with significant updates to Yale's response to the spread of COVID-19. This email came before we even had any cases locally, but we knew from what was going on in Italy and parts of Europe and in Asia that this was going to come to us, and it was just a matter of time. So I'm now going to show you the fine points of this email. So these were actions that were going to minimize close proximity interaction among members of our community in classrooms, dining halls, residential colleges, and other common facilities. This was during spring break. Students were gone. So we were to move classes online when they resume after spring recess, asking students to remain home or return home when possible, limiting international and domestic travel. In other words, we were told you're not allowed to travel, maintaining the continuity of research, and ensuring staff operations and well-being, and restricting the size of events. We weren't allowed to go into any event that had more than a very small number of people. So what happened? Students were stranded, and they were stranded in some cases all over the world. I had students who were on spring break in Florida who lived in England. They could not come back to Yale, and they could not get back to England because of all the restrictions on travel, and they were a real big issue. They could not get home. They could not return to the residential colleges that had basically closed. The professors now had to teach remotely when college resumed. It was all going to be virtual. Our clinics became telemedicine clinics almost overnight. We had no choice. We had a lot of patients. We had a lot of clinics. Patients needed to be seen. And that was only the beginning. That was before we hardly had any cases. What was happening to everybody's sleep? Well, from the very beginning, there were big sleep concerns. And this was among the public. Look at these dates, March 21st, 2020, insomnia. Anyone else having pandemic insomnia and afraid to fall asleep? Just me? Finally turned off the cyclical news stories, but I think they've already done their damage. And so all over social media, there were really hundreds, if not thousands, of messages like this about insomnia, pandemic insomnia. And then there were people that complained of weird dreams. And people were complaining of more dreams, unusual dreams, and having a lot of nightmares. And people, again, all over social media were actually talking about this. And again, this was very early on in the pandemic, extremely early on in the pandemic, when there were hardly any cases. Right away, medication use changed. And this slide shows what happened in terms of the prescription for medications for depression, anxiety, and insomnia between January the 19th and March the 15th. Again, as I said, this is US data. This was before there were hardly any cases in the US. Prescriptions filled per week for antidepressants, anti-anxiety, and anti-insomnia medications increased 21% between February 16th and March the 15th, having been stable actually for very long periods of time. So medication use changed. Well, we were now in the middle of a pandemic, which, as you know, began in China. And what you see below is the days after the first case. And by October, end of October, virtually the same date as we're talking about roughly, there wasn't a single place on the planet that did not have significant amounts of COVID. It was a pandemic that had engulfed the entire world. Now, sleep problems occur during and after catastrophes, all catastrophes. And I'm going to start off with this. Most of you have read this book, The Call of the Wild by Jack London. It was published in 1903. The author was 27 years old. And this, at the time this book was published, it was actually the most popular book ever written in the United States, and it's been translated into like a gazillion languages, and there have been many, many editions. And most of you probably read this sometime in high school. So I happened to be in Glen Ellen, California, when I came across Jack London's home. And this is a poster in his home. Jack London's life ended in this room on November the 22nd, 1916. He was just 40 years old and suffered from a variety of ailments. And this picture was taken 6 days before he died. So this is Jack London's bedroom, and this is his bed on the bottom of the slide. And what you could see suspended above the bed is a clothesline. Attached to the clothesline are clothespins, and the clothespins are holding notes. Jack London had severe insomnia, and when he was awake in the middle of the night, he would write himself notes and ideas to help at least accomplish something with respect to his career, which was that of an author. So in 1906, 3 years after the book was published, Jack London witnessed firsthand the catastrophic disaster caused by the San Francisco earthquake of April 18th, 1906. So he went into San Francisco, and this is the kind of thing that he saw. He saw destruction, he saw fires, he saw buildings that had fallen apart, he saw animals that had been consumed by fire, and this was a very terrible scene. And he then developed severe insomnia. And he wrote about this. My sleep was broken by miserable nightmares. Earthquake seemed the favorite affliction. He became addicted to products to help him sleep. He died at the age of 40. And these are just some of the, this is actually a photograph that I took of the medicine cabinet that actually contained a bunch of opiates that he used to help him sleep. And that's what ultimately killed him. So he developed insomnia. He developed insomnia having seen something terrible. And insomnia often begins that way. It can start when there's an acute illness, emotional stress, papers are due, dissertation exams, seeing something terrible, acute insomnia. Generally that lasts a few nights a week, 1 to 2 weeks, and that's usually about it. However, when something like a pandemic occurs, and this pandemic becomes more or less chronic, the acute insomnia can become chronic. It can become chronic, and what actually may occur is that the person, especially if the pandemic is associated with a lot of stress, as it frequently is, chronic stress, hyperarousal, or learned counterproductive behaviors will contribute to the insomnia, and it'll become chronic, and the insomnia is now going to be present for months, sometimes decades. In other words, something that can start off acutely can become chronic, and it can last for a very, very long period of time. So what is going on in the brain in insomnia? I mean, basically, if you're having a lot of trouble sleeping, what's keeping you from falling asleep is something that is going on in your brain. And it turns out that arousal systems in insomnia subjects do not deactivate from waking to sleep. In other words, what this means is that some of the brain structures that are involved in keeping you aroused or awake, the ascending reticular activating system, here abbreviated ARAS, that does not deactivate properly in people with insomnia. So we're talking about a hyperarousal state. So insomnia is therefore a manifestation of behavioral, psychological, or biologic dysfunction as a result of this hyperarousal. And this hyperarousal occurs and starts, if you will, during the daytime. And it's not just at night that people are hyperaroused. And we are hyperaroused because of the changes in our world related to the pandemic. So what was my reality? I'm going to show you the impact of COVID-19 at Yale. So what I'm showing you here is what happened between March 2020 and the summer of 2020. And what I'm showing you here is the number of patients who were in the hospital over that 4-month period, and those were on ventilators. So as I mentioned before, early March, when I got that infamous email, there were like virtually no patients that had COVID either in the hospital or on ventilators. And by third week of April, we had a maximal number of 450 patients in the hospital at one time, and about just a little bit over 70 of them were on ventilators. And look at what happened in the next couple of months. The number of patients dropped and dropped and dropped. So by July, there were almost no patients in the hospital. There were 15 that had COVID, and only 2 were on ventilators in the hospital. So we thought, my gosh, this thing is over. We don't have to worry anymore about COVID. This pandemic is over. Well, it wasn't over. Wasn't even close to being over. So what I just showed you was this very first peak out here, okay, April of 2020. And since April 2020, we have had 1, 2, 3, 4, 5 peaks, 5 waves of COVID that have swept over the country, sometimes in different parts of the country, and basically even as of very recent times. This is data from October 22nd, just a few days ago. There were over 80,000 cases of COVID every day. So what happened was, of course, the Delta variant. So between June and July of 2021, the Delta variant played havoc with the prevalence of coronavirus in the United States. And Americans are still dying. They're dying at the rate of about 1,500 patients a day. That number is dropping just as there were, if you will, waves of cases, there were waves of death. And look at this very first wave. We didn't, at that point, know how to treat. We didn't even know how to treat COVID. And as we learned how to treat COVID, we got much better at keeping patients alive. And the peak was somewhere in the very beginning of 2021, when there were over 4,000 deaths a day. Over 4,000 deaths a day. And vaccination, the vaccines were approved on December the 11th, 2020. So this is the trajectory that we have seen of COVID. So we've lived through a lot of things, and I've lived through a lot of things, and many of you have lived through a lot of things. We've lived through wars. We've lived through polio. We've lived through pandemics of AIDS, HIV, 9/11, hurricanes, floods, superstorms, you name it. We have lived through many, many things. And the greatest impact in terms of what we have lived through have been wars, okay? Now, what we're looking at on this slide is wars the US has lived through. And what we're looking at here are the various wars and the number of people that died in that war. The largest number of deaths occurred during the Civil War. It was estimated that there were approximately 750,000 people that died during that war, averaging 520 deaths per day. Then we have World War II, World War I, and together approximately just a bit over 500,000 people who died. Vietnam, which is a war that I remember very, very well, following the news of that war, 58,000 deaths. And so we have lived through a lot of wars, and I want to put COVID, which is really a war, into perspective. So with the Vietnam War was from 61 to 75. On the average, there were 11 deaths a day. The worst year in Vietnam, 1968, there were 46 deaths a day. Right now, there have been over 750,000 deaths in the United States. The United States has lost more people to COVID than in the Civil War, more than in World War I and II. The first case in the US was January the 20th, 2020. And since then, on the average, there have been 1,100, almost 1,200 deaths per day. We're talking about a catastrophe. We are talking about a catastrophe that has killed so many people. Our world has changed. This is what a courtroom looks like when it's not on Zoom. Imagine that this is the start of your day. How was your sleep the night before? This is the end of your day or night. What's your sleep going to be like that night? Can you even go home to your family, having you've just taken care of a bunch of COVID patients? Can you even go home to your family? For many, this has become your day or night, sitting in front of a computer on Zoom, doing whatever you do, except you're doing this at home at odd hours. So the circadian rhythm for sleep, wake, and meals is now all messed up, all messed up. Your world has changed. Going to a grocery store, at least early on during the pandemic, was a big deal. You wore masks. Some people wore gloves. And the thinking was, will I transmit COVID? Will I get COVID? And there was a certain degree of sort of mass worry, terror, stress, whatever you want to call it. And even today, we think about today. We think about today, the impact of this pandemic on us today. Can I give my family COVID? I see patients in my clinic, or if I precept fellows seeing patients. Some of the patients are unvaccinated. Some of them may have COVID. Can I give COVID to my family? So right now, I see patients wearing masks, face shields, you name it. I don't even know what my patients look like anymore because they're wearing masks. I wonder where, we used to wonder, where's the next meal coming from, especially earlier on during the pandemic. And many of us ended up buying groceries using services we never used before, Instacart as an example. Some of you probably started to do that as well. We became isolated in a lot of ways. We became isolated in a lot of ways. We were separated from our families for Thanksgiving and so forth in very many cases. And there was this isolation, and there was this disconnect where all of a sudden, COVID had an impact on your life your family in a very serious way. I heard just today, actually, from a patient whose daughter was supposed to be getting married this weekend, and the groom got COVID, and the wedding had to be called off. Can you imagine? Again, the Zoom sessions. Exercise decreased, and a lot of the clubs that we might have gone to, a lot of the gyms, they closed. And many people spent hours watching programs that they would never have watched had there not been COVID, on streaming services, for example, like Netflix. And people started to do crazy things, like baking sourdough bread when they had never, ever in their whole life shown any interest in baking. So this is what occupied people, and still occupies many people, depending on where they live, about today. And we were also thinking about tomorrow. So I can tell you that a year ago, when there were no students physically at Yale in the fall semester, you're thinking, will Yale still be around long term? We didn't know, because we didn't know how the pandemic is going to turn out. There were no vaccines about a year ago. We still think about, will I get COVID even though I've been vaccinated? When will I see all my friends again living in other countries? I have not seen my sister, who lives in Canada. I haven't seen her in a couple of years. What about life outside? When will I see my kids again? I know of several families where the parents have not been able to see their kids because their kids live far away and they're hard to get to. One of our trainees today said that she finally feels comfortable enough to fly and see her parents that she has not physically seen or hugged in about 2 years. What about vaccination? There's a lot of worry about vaccination. Do I get vaccinated? Do I get a booster? Will I need a fourth shot? Are the patients that I'm seeing vaccinated? These are things that we think about. What about nursing homes? The people that I know who might be going into nursing homes, are they even safe for people? So these are things. And when will I travel again? And what is going to be the new norm? So as the year went on, there were, you were confronted by terrible news. And the news that struck me the most, one of the things that struck me the most was this article. Terrible news. Top ER doctor who treated virus patients dies by suicide. And she had, apparently, from an interview that I saw with her sister, she had trouble sleeping before, leading up to her suicide. I didn't know her, but this is someone that I did know. He was a colleague, a pulmonologist, who died very early on during the pandemic, April the 16th. And this was the height. This was the height of COVID in my community. And, he passed away. And this was sort of a new phenomenon, something I'd never experienced before, of someone who shouldn't have died, who died very, very quickly. Well, here's someone that exemplified great news. This was another colleague, and this colleague was in California. He got COVID, and he was on a ventilator in drug-induced coma for about 2 weeks, and I didn't think he would make it. He made it, and this is a photograph taken when he was being wheeled out of the intensive care unit. You'll notice that there's an oxygen canister next to him, and he's wearing prongs underneath his mask, which you cannot see, but you can just barely see the tubing in his neck. So meanwhile, late in 2020, we were all living through something else. And the something else we were living through was an election. And so this election was causing a huge amount of stress in the general population. Huge amount of stress in the general population, because this election was being held in the middle of a pandemic that was killing thousands of people daily. So our emotions were going up and down, leaving us dizzy and confused. So all of the things that I just mentioned, they mess up circadian rhythms. They lead to hyperarousal. They lead to dramatic mood swings, changes in the brain, insomnia, hypersomnia, weird dreams or nightmares. So all of the things that I just mentioned had a dramatic effect on sleep. And I want to come back to Jack London for a minute here, because Jack London, today, we would have said that he had post-traumatic stress disorder. He had nightmares related to what he had seen. And this is something that we are going to see in caregivers who had taken care of patients during the pandemic. We're going to see this type of thing in family members of patients who died or were very, very sick. So the nightmares in post-traumatic stress disorder, they're repetitive. They replay the psychologically traumatic event. The patient wakes up at night in a sweat, heart beating fast, frightened, and they can develop a fear of falling asleep, because who wants to fall asleep when you're going to have terrible nightmares that are going to be really disturbing? The nightmares of post-traumatic stress disorder can be present. The most dramatic case that I've seen in my career was a gentleman who 70 years after a traumatic event, he was a Holocaust survivor from the Second World War, and he still had nightmares 70 years after the war was over. So far we've been talking about people, the general public. We haven't talked about people who actually got COVID. And as you know, there's a spectrum on people who get COVID. Some people are totally asymptomatic. Others become sicker and sicker, and they end up on ventilators, and many of them die. So we know, and we started to learn very early on in the pandemic that there are phases to patients who develop COVID involving their respiratory system. There's an early phase, and the early phase can be cough, insomnia, diarrhea, headaches, and there are certain laboratory findings. And there are certain treatments that we now use. And then there's what I'm calling a pulmonary phase, where it's not just the virus that is causing symptoms, it's now lung disease that is causing symptoms, pneumonia-like cough, shortness of breath, insomnia, and patients now had hypoxemia, abnormal lung imaging. And then there was the hyperinflammatory phase, ARDS, shock, cardiac failure, and one could measure inflammatory markers. So COVID, in terms of the respiratory system, there were different sides of the spectrum. There were those who had almost no symptoms, and those who ended up on a ventilator requiring all sorts of treatment. Many of those patients died. So what makes COVID severe? We know about some of the risk factors for COVID: being obese, being African American, for example, having diabetes, and so forth. But what ends up happening is someone gets infected, and there's a cascade of events that happens, and I've labeled them here A, B, C, D, and E. And each one of them involves blood cells, chemicals. So there are degranulating neutrophils that release resistin and other chemicals that actually damage the lung. So this is a pathway that has been fairly well characterized. So that was the infection of the lungs. What about infection of the nervous system? You've heard that patients very often lose their sense of smell. The nervous system can be infected via the olfactory bulb. Okay, in other words, the virus can go from the nose to the olfactory bulb and straight into the brain. It can also get into the brain via the circulation. For example, the virus can come from the respiratory system into the circulation and end up in the brain that way. There's also an effect on the heart, on the cardiovascular system. And I can't show you or talk about all the mechanisms, except to let you know that there are a lot of reasons why the heart and the cardiovascular system are affected. And at the end of the day, patients may end up with heart failure. And frequently the patients who die in the hospital have heart failure. If they go home with heart failure or develop heart failure because of some of the long COVID issues that I'm going to talk about later, they may develop sleep disordered breathing. They may develop a Cheyne-Stokes breathing pattern, which, as many of you know, is associated with sleep issues, insomnia, for example. So we've talked about patients who got COVID and got sick. What about the lucky ones who recovered from COVID infection? So you've all heard of post-COVID, also known as long COVID, long haul syndrome. There are many names for really the same thing, basically talking about patients who've had COVID who now have symptoms. And it turns out that even patients that had fairly mild COVID can have symptoms, and I'm going to give you some examples in a few minutes. So post-COVID patients will have psychological issues, respiratory issues, neurological issues, and cardiovascular issues, and others. And all of them, all of the chronic issues that you've heard about in post-COVID, the long COVID patients can lead to sleep problems. So I'm going to just review some phenotypes of post-COVID patients that I have seen in my clinics. So here's one phenotype, which I'm calling post-COVID insomnia psychological type. The patient was a perfect sleeper. He actually got COVID while he was living in New York very early on in the pandemic. He was a perfect sleeper until he got COVID. He got a respiratory infection, fever, cough, shortness of breath. He recovered completely from COVID, moved to Connecticut, and he contacts our clinic because he now has severe sleep onset and sleep maintenance insomnia with post-traumatic stress-like symptoms with recurring nightmares. And he had developed a fear of falling asleep, and he was suicidal. Okay, perfect sleeper until he got sick, recovered completely from the infection, and now suicidal. Here's another phenotype, post-COVID insomnia neurological type. Perfect sleeper until got mild COVID respiratory infection, fever, cough, shortness of breath, recovered from COVID, but developed insomnia with a perception of awakening and not breathing. Okay, no more lung disease, but he was waking up with a perception of not breathing. He got an oximeter, which indicated hypoxemia during sleep, and he was left with severe sleep onset and sleep maintenance insomnia with the fear of falling asleep. And here's a letter that he wrote me, a note. I have never had any trouble sleeping or falling asleep, so when I couldn't fall asleep on May the 8th, that was 2020, it was jarring. At night, lying flat made it harder to breathe, so I was mostly upright. I would fall asleep, and then after what felt like just a moment after falling into sleep, I would kick awake, gasping for air with the feeling of having just stopped breathing. This happened every time I would try to sleep. We had purchased an oximeter, so after the first time gasping for air that night, I put it on, and my wife observed the readings as I tried to go to sleep. And this was between 11 p.m. and 12 a.m. So he documented drops in his saturation when he awakened with the perception of not breathing. Well, this patient got another oximeter. It wasn't just a spot reading. He bought another oximeter that actually measured oxygen saturation continuously. And here we see all night data. And boy, this patient had findings that are characteristic. You see this very, very broad band of oxygen saturation with values going into the lowest value here is in the 60s. And he had very severe sleep apnea. Post-COVID insomnia, respiratory type, perfect sleeper until got COVID respiratory infection, again, fever, cough, shortness of breath, hospitalized for weeks on high flow oxygen. He was never on a ventilator, recovering from COVID. Actually, 16 months post-discharge, he's still on oxygen, cannot exercise, oxygen saturation drops with exercise, and sleep. His oxygen saturation drops when he slept. He's left with severe sleep onset and sleep maintenance insomnia. Again, has a fear of falling asleep. Now, this patient that I just mentioned, he got an oximeter that measured oxygen all night. And what we're looking at here on the panel on top are the number of episodes of oxygen desaturation while he slept. Okay, so he wore nothing in the first 3 hours. Then from the 4th hour on, he started going. He put himself on oxygen at 3 liters. So here he is before the oxygen, and there he is after the oxygen. And this patient had sleep disordered breathing, hypoxemia during sleep. And frankly, we don't have enough data yet on patients like him to understand in detail what is going on. So are the things that I've described unusual? Well, we are beginning to see a lot of data. And at 3 months post-discharge from an ICU in patients who had ARDS, the most frequent symptoms were dyspnea in about half and cough, continuing cough in about a third. Over 3/4 of the patients had decreased lung diffusing capacity, and they were unable to walk as far as they did before. And CT scans were still very unusual in most of the patients. And there are a lot of studies that are emerging on with post-COVID. So there are long-term neurological and psychological effects. And there's a lot of data coming out on this, and I'm just going to focus on the sleep-related symptoms. So if you look at a large cohort of patients, these are patients less than or more than 75 years old. About half of all patients have insomnia, and about 1 in 7 have symptoms of post-traumatic stress disorder. And it didn't much matter whether patients were less than or more than 75 years old. They tended to have problems with their sleep. Now, if we look at other phenotypes with patients who had persistent neurological symptoms, again, we see that insomnia was found in about 3/4 of patients, and 1/3 of them roughly had symptoms of post-traumatic stress disorder. In other words, nightmares and stuff like that. And the same thing was true if they had persistent respiratory symptoms. So this brings us to this, that there have been phenotypes that have emerged. And the phenotypes that have emerged fall into 3 buckets: cognitive, respiratory, and neurological. And in these buckets, the main symptoms are cognitive, in other words, brain fog, unable to remember things and so forth. Respiratory, shortness of breath is a real big one. And neurological, which is fatigue, overwhelming fatigue. So we have the main phenotypes, and the last thing I want to mention about this is that we are going to be seeing, and we've already seen, mixed phenotypes, where a patient, for example, can have neurological issues, the patient can have respiratory issues, can have cognitive issues. And so what we're going to see, and we've already started to see, and we're still teasing a lot of this apart, are patients that have problems in more than one organ system, if you will. And of course, other phenotypes are going to emerge. So I want to end by telling you something about where this pandemic sits and how it compares to other pandemics that we have had. So somewhere between, right now, somewhere between 4 and 5 million people have died worldwide of COVID. The Black Death, the bubonic plague in the 1300s, over a course of just like 4 or 5 years, 200 million people died. The Spanish flu about 100 years ago, 40 to 50 million people have died. HIV, AIDS, 25 to 35 million people died. And I don't want to trivialize the number of people that have died of COVID, but what I do want to mention is that the world, society, people have lived through terrible, terrible plagues, terrible diseases, and we will get over this one as well. It'll be tough. It's not over yet. And I want to end by really with this hopeful message. We will return to normality. It may be different, but we will celebrate births and birthdays. We will attend gatherings at homes and houses of worship and sporting events. We will shop and travel, eat in restaurants and hug each other. We will celebrate life. Thank you.